I did want to begin with a question that was submitted earlier, and I'll just go around the horn for each of you to touch on this. I think one of the questions I have, after I raise the questions that are in the Q&A currently, is just, hearing from others, doing the work that you're doing, what really resonates to you, just to reaffirm a strategy that's been found helpful elsewhere that's helpful for you already, or were there some innovative strategies that popped up that you find, of interest that it could be implemented in your area? But one of the first questions was regarding who is paying, what's the source of support for testing, in particular, the cost of treatment for these populations. And then secondly, what are the strategies for adherence to treatment, for this population, which is often mobile or is not always in the same place for a variety of reasons. So those adherence strategies, some of those we heard from, but just want to go around and talk about, hear about the support for cost of testing and treatment, and to call out particular strategies that promote adherence. And we'll just start with Joshua, just to get us going from LA. Thank you.
Sure. Yeah. So in terms of cost for treatment, the ways in which we have received funding, we have received federal funding. We've also applied for grants as well, and we work with the Department of Public Health, both the LA Department of Public Health as well as the California Department of Public Health, in order to help us funding. They provide the rapid tests that we use as well. So those are the different types of grant funding and different partner organizations that we work with.
Okay. And any particular key strategies for promoting adherence? It's very impressive, the high percentage of people you're getting into care.
Yeah, for promoting adherence, I would say definitely waiting for the patient to be ready for their treatment, because the best time for the patient is the best time to start treatment. And so waiting until they're ready to be able to adhere. And also, I guess, emphasizing again that care coordination role of helping patients through their treatment has been very important for adherence as well.
Elaine, please.
Yes, thank you. So I think with us, the funding has been predominantly through research projects and some of the HIV leftover funding, if I can call it that, for a lack of better words. So a sub portion of HIV budgets, which is often still international donors. But I do believe we are moving towards domestic funding for some high-risk populations. And then in terms of adherence, I think I did mention a few things in terms of our drop-in centers. What I can add would be really to make sure the patients are enrolled in other services as well, not just hepatitis C, so the integrated approach. And for our linkage to care, when patients require to go to hospital, we also make use of what we call a health passport, so patient health document that becomes the identity document, as a lot of the individuals are undocumented as well.
Thank you. Mandana?
Yes, thank you for that question. I think there were also the issue of adherence to medication, as you mentioned, John, that came up as well. So the cost, we wanted to ensure that this was a sustainable process, and we work within the system that we live in order to be able to provide patients access to these treatments. So that was through government insurance, whether it be Medicaid or with some cases, patients were veterans, so they had Veterans Affairs health care system linkages. And additionally, when there was no such sources, we went ahead and applied for the patient assistance programs with the drug companies that provide hepatitis C directly. And everybody was a candidate based on lack of access through other means. So we were able to provide those treatments in such a way, and also set up services within the shelters themselves so that process became facilitated. The issue about medication adherence was really important, and thank you, Tiffany, for that question. question. This came up numerous times when we looked at actual complete adherence to medications, whether it be all doses of drugs. We were looking at less than 40% with patient report and provider report. When we looked at full duration of adherence, we were looking at less than 50% or around 50% adherence. But if you're looking at majority, sort of at least 80% of doses and duration, we got somewhere around the numbers that I shared with you earlier, about 80-some% from a patient perspective and less so from the provider perspective. I think what the main concerns here were about how the medications were kept and stored. And I think there were many, and the fear about sort of these very expensive medications being on persons and not being accessible to the clients. So we provided lockers and locks for those lockers within the shelters if patients wanted to keep them within the shelter. We did the direct observed therapy if needed when there was no possibility of doing so. And I also worked with, other means in which we could keep medication safe within the shelter system. And it was also existing for other types of treatments as well. I also provided the link to our publication for additional specific information. Needless to say, shorter duration of treatment had higher adherence, longer duration of treatment had lower adherence, as it would be expected. Thank you.
Thank you so much. Bernadette, Doug, please.
Amazing. So I think it's really interesting. We can talk about like population level interventions, but I think we always have to remember the individual, and that individual need assessments drive good care, right? So when we're talking about adherence for individuals, a lot of it is dependent on exactly what that person is telling us they need, right? So if somebody wants to do daily dispense, we can do daily dispense at a pharmacy. If somebody wants a week of medication at a time, a week of medication at a time is what we do. If it's a month at a time, then that's all right as well. Part of what we end up talking about is that people can just always come back. If something happens, come back to us and we'll figure it out, right? So I think a lot of times when people are told that adherence has to be as close to 100% as possible for treatment success, people end up having a slip up and then they don't come back because they feel like, oh, well, I messed it up and what's the point of even reconnecting? So really it's about like that open door policy of always bringing people back in. Doug is also really great at finding people in the community, rides an e-bike around downtown Toronto on a regular basis. So people that we don't think that we are going to be able to find again, Doug's like, oh,
we find them.
Yeah, exactly. So also being linked into correctional services in shelters, all of that kind of stuff helps. When we're talking about funding for medication in Ontario, as well as for the Ontario Hepatitis C treatment teams, we're really lucky the Provincial Ministry of Health has funded Ontario treatment teams. So that's these multidisciplinary teams that are embedded in different places within the province, and that's ongoing funding that we're able to get. For medication coverage, for people who are on social assistance, it's automatically covered through the Ontario Drug Benefits Program, so people can access medication that way. If people aren't on social assistance, there's private insurance that can pay Trillium drug benefits, which allow people who are lower income to have a deductible that is based on their income, so drug costs can be affordable. And then we also use pharmaceutical compassionate or patient assistant programs to pay for some individuals. Sometimes we have people who have no status at all, and then oftentimes it's compassionate access through pharmaceutical programs. One of the things that we ended up finding, we did a research study on hepatitis C antibody testing, where we gave antibody tests to folks with lived experience in the community, and they went out and tested a bunch of people. And we saw that there was good uptake for testing, but really poor linkage to care. So we've shifted our focus from testing being the thing to focusing on the linkage to care. So we now use treatment navigators, people who are connected to an individual and follow them through on treatment. Somebody who's had experience of going through hepatitis C treatment is embedded in the community, doing the work alongside somebody, as opposed to a treatment navigator or somebody who's further removed from that. So we pair people up to have somebody who's able to go through the entire process with them, which has been really successful. And actually at this point in time, we haven't had any treatment failures that we haven't been able to retreat and cure of hepatitis C. And that's in the lifetime of the program, which is, pretty remarkable given the level of complexity and instability that a lot of people end up experiencing who we work with.
Thank you. And to that latter point, I want to turn to Mandana for a moment, because it caught my eye that of those that were being found HCV antibody positive, in your sites, a high percentage had been tested previously. And so I wondered, does that reflect poor linkages to care previously? What do you think? What was your program providing that wasn't available to those populations that had already been tested and found to have been infected with HCV before?
No, absolutely. Thank you for that really important question. I think there was, this is a little bit of a skewed situation in that there has been a tremendous amount of efforts within the city of San Francisco in promoting testing. And as I shared with you, we have this End Hep C campaign, which involves multiple community organizations, healthcare services, and other entities in order to promote testing. And while testing was conducted, I think that the next steps of confirmations of infection, so active infection, and then also linkage to treatment were essentially where the drop-off had happened with ensuring that the patients go through the whole cascade of treatment. And so this is where, I think our focus on the next steps of confirmation and treatment was really important. And I also highlighted that, the importance of testing is ineffective if the next steps are not followed in HCV elimination. So that was quite eye-opening for us.
Thank you. Josh, there was a question about your database, about the homeless, a database that collects medical information, that's really quite impressive. Data is really good data. It's hard to come by for HCV incidence, prevalence, and mortality overall, particularly for a marginalized population for homeless. So it's really, very exciting to see that that's being supported by the LA County, apparently. So I just think there were some questions about, is that indeed, supported by LA County? How well is it being supported? How is it linked to overall disease surveillance for hepatitis C, please?
Right, yeah. So yeah, the database is managed by the LA Homeless Services Authority. And so whatever information and data that they have, they put it into that database that is available for people to use. And so it has all sorts of information from patient visits to different hospitals. I believe the particular question someone asked was whether a person is incarcerated. So I believe it does have that information as well. And so, yeah, there is a wealth of information that is there at your disposal. So I definitely recommend using that database.
Yeah. Lane, there was a question about the availability of sofosbuvir, the cladosphere. I think, in South Africa, I think you touched on it, but just to give you an opportunity to reaffirm that it's now, nationally approved, drug combination that's available now, rather than just coming in, through some, non-governmental organization processes alone. So if you could comment on that, please.
Yes, so our program was actually implemented prior to that, so we had to do bulk importing, lots of paperwork. But Soval and Soflidipizavir from the originator company is available, so no generics yet. And yes, in our state facilities, it's still at tertiary level, not at primary level. So in the private sectors where you would find it, more at lower levels of care.
Thank you. Mandana, and the other aspect that caught my eye was you mentioning in your sort of focus groups or formative research, you touched on financial incentives, and not just for incentives for the patient or for the client, if you will. We touched on that, but also for the system or for care providers. And we've touched on support for treatment. But what are the important financial incentives to keep in mind for the delivery, of these services, by clinical care providers that are seeking to provide an array of services? How do you get hepatitis C on that agenda? Do you have any thoughts about that, please?
Sure. Thank you for that important question. We didn't specifically get financial incentive as a facilitator from a provider perspective, it was more directed towards patients in having them engage in care. But you're absolutely correct in that there has to be resources devoted to implementing the infrastructure that is needed to address this, and identifying sort of hepatitis C care coordinator individuals, for example, which was a key facilitator that was brought up by these questions that we asked the key stakeholders, to be able to sort of address some competing priorities of these individuals or providers, and addressing many other potential comorbidities within this population requires financial support. So I think from a big picture perspective, showing that these efforts work, and showing that it can be implemented despite suboptimal duration of treatment or adherence to treatment, and the really high cure rates that can be accomplished, it is important to be thoughtful about how to divert those resources from a systems perspective to these efforts.
We only have a few more moments. I did want to go around and just to hear from everyone in two ways. Do you both have very effective programs, but are those programs sufficiently resourced to meet the needs of all the homeless in your communities, or do you really need a great expansion of that? You just can comment on that, please. And then as I go around, if you just could comment to, like I mentioned earlier, to reaffirm any strategies that you heard from others on the call, or some novel strategies that could be brought into your program for consideration going forward. So again, I'll start with Joshua and then work back from there. Yeah, Joshua, any thoughts on that, please?
Yeah, absolutely. So I would say, so we could you repeat the question again?
Just one, do you think your program, your effective program, is large enough to meet the needs of homeless in Los Angeles, or needs to be greatly expanded?
Yeah, I would say, especially in the Skid Row community and the greater LA area, there is a huge need to address homelessness. So I would say we need all the help we can get. We have so many partner organizations that we do work with in order to help address the needs of those in our communities, but constantly needing more people that are motivated to help and who want to help. Not only in our organization, but also in the different organizations that we work with. We always hear greater needs for staff and for people who desire to help. So I would say definitely that is something that is very big. And yeah, I just wanted to reaffirm everyone else, the things that they talked about are some of the things I noticed are things that we tried to implement as well, as like incentives and really waiting for patients to be ready and thinking of the patient first and foremost. Those are all things that I really wanted to reaffirm in everyone else's program as well.
Thank you so much. Elaine, your thoughts, please?
Yes, thank you. So I think what we've done is a drop in the ocean. We're one of two, we 2 of 16 harm reduction sites in the city, and then I'm not even talking of other major cities in the country being affected. So our aim was really to pilot and to show that it can and should be done at community level, but we really hope that it would be scaled through more resources. And then just listening to the other presentations, I appreciated the role of the HIV care coordinator, and I think that's really a space where we have to move into, especially wanting to superimpose it onto our HIV programs that are existing. So that would be very important for us to explore. Thank you.
Thank you so much. Mandana, please.
Thank you. I just wanted to share that thanks to your effort, John, as well as the others within the field, and the focus on policies currently in really testing for hepatitis C in a universal fashion, and importance of hepatitis C elimination. This is at the forefront of the care of our vulnerable patient population. And I think that it is important to note that while we showed one particular model of care delivery that works in meeting the patient, the population or patients that that are where they are. In this case was the shelter themselves. There's been a tremendous amount of efforts that have now been initiated and have been as well previously in place with regards to meeting patients where they're at, meaning whether it's mobile entities, whether it is really expansion of services within the safety net populations, and also obviously the amazing VA model that shows how to do this the right way in those areas. So I think this is just, again, a very much of an effort that needs to garner still partnerships and continue to expand, but thinking more in novel ways is going to be important.
Bernadette and Doug, please.
Expanding testing so we can do treatment. And I also think hiring people with lived experience is a great opportunity.
We find that we can't test 300,000 people ourselves, but we're happy to end up connecting those folks to treatment. So universal testing for everybody, embedded in primary care, in emergency departments. Let's get testing more universally done, and then we're happy to end up treating anybody.
Opt-in, not out.
Thank you. Thank you so much. Excellent overview of your programs that are really reaching this population where otherwise they would not have access to these services. So thank you again very much for your efforts to achieve health equity for these populations. Again, all of this information will be available on our website at globalhep.org. The presentations, the videos of individual presentations, as well as a summary to touch on the highlights from these different presentations. And also, please sign up to our newsletter while you're at globalhep.org so you can keep abreast of the webinars coming up and how you can get involved in other coalition projects and programs and educational efforts. Thank you again for all of your interest and work to achieve goals for hepatitis elimination around the world. Take care. Thank you. Okay, thanks. Thank you all. Great. That was great. Really happy we had an opportunity for you to share your